Going from the very basics to the dream. What is the dream here? The dream is that no one in this audience would not have already had their genome sequenced. It have been appropriately and accurately interpreted. You would know what you were at risk for. Your doctor would always know what to do and what not to do. Risk stratification would save lives at every level. And that's been the dream. But unfortunately, that's been the dream for 20 years. How do we move ourselves closer to that dream? My work has been in the implementation science of genomics. And I'm going to tell you about some of the data that we've gathered in trying to pursue that dream. Declaring, as I always do, my sources of research support are here, as well as the companies to which I consult and the companies that I have co-founded. So why is your doctor, every one of you who's sitting out here in the audience, why is your doctor not insisting that you get your genome sequenced today? And I summarize all the reasons in this one slide. The conditions are too rare. There's not much you can do with it anyway. It's too much information for us to handle. Everybody's going to misunderstand. There are certainly legitimate privacy concerns, but I think they've been exaggerated. And the whole thing's not cost effective. And besides, it's not much you can do about it anyway. And I'd like to propose to you that every single one of these is inaccurate, that they hold on with a kind of zombie hold on our consciousness in genomics, and that we should be working assiduously to create entirely new narratives around genomic medicine, particularly preventive genomic medicine. So the population screening debate, I'm one of those unusual medical geneticists who actually also has a degree in public health. And the population screening debate for any new risk stratification goes a little like this. What can you get from doing this to the entire population? Well, we can figure out those people who actually have a diagnosis of an unsuspected genetic disease. For all of the rest of you, we can stratify your risk, first with monogenic variants and then with polygenic variants. And we can give you additional focus on surveillance and preventive measures to those who are at highest risk. And the zeitgeist has changed, right? People today want to know things, whether or not they can treat them, and that is a fundamental generational change. But what public health people and screening people in particular will tell you is that these are rare conditions individually, not so rare in aggregate. They each have a low prior probability, and you can identify many at-risk individuals who are not going to manifest the condition, probably because of variable penetrance and expressivity. Also, you can spend an awful lot of money and an awful lot of health resources following people who might have a variant who are never going to develop the disease. And you really do have to ask at a societal level whether this is cost-effective, cost-useful. And finally, there is a genuinely big mismatch between what you would need in terms of genomics expertise and the genomics workforce that is already available. So my program is a core program of about 25 or 30 of us, and we focus on cost, benefit, and risk. And I'm fortunate enough to collaborate with a whole series of additional collaborators, too many to list here, but some of the pictures, the most prominent ones, are on here. Particularly for the BabySeq study I'm going to be telling you about, particularly Alan Beggs and Ingrid Holm. Now, we also mentor trainees at every level in case you have college, medical student colleagues, friends, family members, or you would like to rotate through a rotation with us, particularly over the summer for trainees. And we are, like everyone, focusing on diversity, equity, and inclusion in both training and also in trying to answer some of the most fundamental questions that posed by diversity in genomics. 3 of our NIH grants, for example, are firsts. The first to offer whole genome sequencing to African American and Hispanic newborns in our BabySeq project, the first to offer subsidized elective sequencing to healthy African American adults in our PeopleSeq project, and the first to return actionable genomic results to individuals who have been sequenced as part of research in the all-white Framingham Heart Study and the all-African American Jackson Heart Study. Now, we started this about 15 years ago in what we called the MedSeq project, where we were the very first to comprehensively sequence healthy adults, people just like you and me, who did not necessarily have an indication for sequencing. And at the time, and continue to today, this is very controversial because of all the issues I mentioned, and so we randomized people into a sequencing arm and a non-sequencing arm, because if you really want to tell what's the advantages and disadvantages, it helps to have that kind of randomization. This was a time in which there were no clear-cut analytic pathways, and so with help from Heidi Rehm and the Broad and the Laboratory for Molecular Medicine, we created one of the first of these analytic pathways, which are quite common today. We sequenced 100 individuals, randomized another 100 to not sequencing, and in those 100 individuals, looking at over 5,000 disease-associated genes, found that 20% of them were carrying monogenic, unanticipated monogenic risk variants or biallelic monogenic variants. Now think about that, for example. That's all three of those tables right there. All of you are carrying a monogenic risk variant or a biallelic monogenic risk variant. That's pretty startling. And we have found that this has been true in other labs, in other groups, and in our subsequent sequencing. What was also interesting about this group was that a small number of them, when we looked at the patient through the prism of the DNA findings, we found features, clinical features, or laboratory features that had been either missed, not looked for, or misdiagnosed before. This is a bit of a new concept, even still, 10 years later. The idea that DNA is a pathway to diagnosing something you already have but didn't recognize as a genetic syndrome. We've been so caught up in children and hereditary that we forget that there's a lot of genetics out here that isn't even recognized as genetics. We looked carefully at spending and could find that the individuals who carried these three tables, did indeed spend more on downstream medical costs, but not a huge amount more. And that unending narrative of catastrophic psychological distress, I'm here to tell you that we've looked at it 12 ways from Sunday, and it simply isn't true. This is just one of many publications we've done where the group that was sequenced, the group that had returned results, had no difference on sensitive, qualitative, quantitative, standardized scales of anxiety and distress. So if sequencing these three tables is good now, wouldn't it have even been better to sequence those three tables when they were babies? And that became the basis of the BabySeq project, which is the world's first project to actually comprehensively sequence apparently healthy newborn babies. This was funded in 2015, and again, we used this idea of a randomized clinical trial to get started. Very straightforward. We randomized people into the classic state-mandated newborn screening, a good family history, versus all of that, plus comprehensive sequencing, again, of over 5,000 genes. But now we had to decide which genes do we return. We wanted to be a little bit more inclusive, so we didn't worry too much about actionability per se, but leaned into disease gene validity, increased penetrance, and of course age of onset, and came up with about 884 genes. We then added back in the actionable genes from the ACMG list, which includes some adult onset conditions. Very controversial to some, makes perfect sense to others. And then we decided to look within that group. Now, what percentage? This is a lot less than the 5,000 genes in the adults, so it's going to be lower than 20%. But I have to tell you, as a medical geneticist, when you asked me, like, what percentage of babies were going to have this, I would have said 2%, 3%. It turns out, I'll tell you that in the next slide, that people were very, very interested in this. When we would go into the birthing room at the Brigham and Women's Hospital, we would find that 70% of individuals were interested in getting the DNA of their baby sequenced. Now, when we came back into those rooms with a 12-page consent form and told them we had to stick those babies again for their blood, there was not quite as much enthusiasm. This slide on the bottom has been misinterpreted as saying families don't want this service. I think they do, but we presented it in possibly the most unpalatable method possible. Well, here's the answer to the question I posed before. A striking 11% of these babies had monogenic disease risk. That's about 2 tables over there. So 2 out of all these tables are going to have monogenic disease risk. And again, there were syndromes that were identified which were not previously identified in those ostensibly healthy babies. So let me show you an example. The third line down there is an elastin mutation. That baby was perfectly healthy, had normal heart sounds, and then when that baby had an echocardiogram, the aorta was abnormally narrowed. Now, we don't know if that baby's going to go on to have any difficulties in life. They might not. But if that baby goes out and starts fainting on the playground as they play on the jungle gym, then I think we're going to want to know that this predisposition is going on. And here's one of the most startling things of all. This slide is brand new data, never been shown in public yet, under review. Of the 18 babies who had unanticipated monogenic findings, remember there were a few that had adult onset conditions, this generated 16 specialist consultations, 8 ongoing surveillance efforts, 7 imaging studies, 4 phenotypes, and down the list that you can see there, in the babies themselves. Now, on the face of it, that's not too surprising. We found a risk factor. Babies were worked up. But look at the second layer on the right. It turns out these families, without a lot of urging from us, communicated these risks throughout the families, and other family members were worked up as well. This is cascade testing from the ground up. And I was stunned to find in the end that 2 of the babies with BRCA mutations sponsored quite a lot of adult testing for BRCA2, and down the road, within 3 or 4 years, 2 risk-reducing surgeries in adult relatives of these babies. This has never been reported before. It's really exciting because it suggests a whole new entree into that inaccessible ground of cascade testing where we all know the prior probability is so much higher in the relatives of a proband who's carrying such a mutation. Since we were sequencing so many genes, we were also able to report out on recessive carrier variants. And our babies, 88% of our babies had a pathogenic or likely pathogenic variant in a recessive carrier, which of course most of the time was not going to affect their own health, although there's this really interesting strain of work in manifesting heterozygotes, but was instantaneously far more information than you get from even the largest panel on a commercial preconception screening panel. And once again, tremendous amount of ink has been spilled speculating on what kind of psychology will occur in parents whose babies are sequenced. Are they going to get overly anxious? Are they going to get depressed? Are they going to disrupt parent-child bonding? Well, once again, there are validated scales of all these measures, and the randomized clinical trial methodology gives you tremendous power to look at this and say with confidence, no, they are not going to experience these things. I'm not saying that parents weren't briefly upset. They were, and we could measure that. But these parents were resilient. They were self-selected to participate in this, and the results were quite fulfilling from the point of view of not hurting these families. Once again, we could track healthcare spending in the 1 year following the disclosure. And while it is higher, it's not so much higher that it's going to break the bank, or the phrase that the LC people have been using for years is robbing the medical commons. It does not appear that by identifying these risk factors, we are going to disproportionately take away medical resources. So there's a lot more work we've done, including a whole strain of work through the eMERGE study on polygenic risk scores that we measured in our original MedSeq and that we continued to some degree in BabySeq. But if you take a snapshot of everyone in this audience and you ask what percentage, if you did a comprehensive genome, this is our estimate of what you would find. 15% of you, between 11 and 20, would find you are carrying a dominant or biallelic mutation in an unanticipated, fully well-established disease-associated gene. Over 90% of you would be carrying a recessive mutation. 80% plus would be carrying an atypical pharmacogenomic variant. And well over 50% of you are carrying something in the highest couple of percentiles for a polygenic risk score for a common complex disease like coronary artery disease, like type 2 diabetes, like atrial fibrillation, common variety cancers. So if you look at this, there's a lot of information there, and then it becomes a true implementation challenge of enormous proportions to somehow bring this into the workflow of everyday medicine. We all understand why that's so intimidating and why that's such an issue. So what about the possibility of universal newborn sequencing? We heard a wonderful visionary challenge from Stephen Kingsmore this morning. But having actually done this with real patients, real parents, real rejections, real questions, I can tell you that some of the possibilities are going to be very difficult to implement, but we absolutely must try. And this is because, as you all know, there's a bit of a catechism. Rare diseases are not rare in the aggregate, and they are becoming increasingly treatable with medications, with surgeries, with gene-targeted therapies. There are 4, count them, 4 gene-targeted therapies that are FDA approved right now. There are 400 in development. We are woefully unprepared to meet the challenge of identifying these babies early and getting them into the treatment pathways that they will need. Here's another graphic reminder of what is on the recommended uniform screening panel that is subsumed by the current state-mandated newborn screening system and what is happening in terms of treatable conditions. So I'm really excited to announce that Stephen and myself and Melissa Wasserstein and a number of other people working in this space, David Bick at the UK, are establishing something we're going to call an International Newborn Sequencing Consortium. In BabySeq alone, we hope to grow. We've gotten refunded by NIH to do BabySeq at 4 more sites, multi-ethnic sites. We're going to have the first scholarly meeting of this group in Boston on October 5th and 6th of this year. Mark your calendars now, and we'll be getting the word out for that. We'd love to see you there. And we think that this is a pivotal moment in human history where we really have to re-examine all of our assumptions and narratives about predictive genomic screening in order to meet the challenge of looking forward, not just for babies, but for our whole life. You know, NICU babies has kind of been the quintessential example of what it means to have a terribly sick baby and to use genomics to make a molecular diagnosis and speed treatment. And you can think of that as obviously highly enriched for genetic conditions. The PPV is super high. But what if you turn this model on its head? Thank you very much. This is my absolute apex of slide making ability. And you ended up sequencing all babies first. You could then not diagnose. Whenever you hear somebody talking about newborn sequencing and they use the word diagnose, just slap them. It's not about diagnosis. It's wrong to talk about diagnosis. You will not accurately diagnose babies who are apparently well. What you will do is you will move them up or down in terms of risk stratification by virtue of the DNA variants that they are carrying. You can then medically contextualize that variant. You can ask, oh, do they have a funny skin rash? Do they have more hearing loss than we were aware of? Should we be on the lookout for visual symptoms? Is this going to be a baby whose motor tone is a little reduced or whose milestones start coming a little bit slowly? You are sensitized to an earlier diagnosis. You can then use that information not to just diagnose, but to think about the rest of the family. You can cascade test, as you saw in our early proof of concept. You can look for orthogonal biomarkers, make entire industries out of orthogonal biomarkers that would help differentiate those that are high risk from those that are actually going to go ahead and manifest the disease. And you can move from no phenotype to the awareness of subtle phenotypes and eventually preempt the development of obvious phenotypes. So this is the dream. And as others have shown, as Ed showed in one of his slides, the idea is genomically integrated healthcare, changing our healthcare system from its current status as a reactive sick care system to a proactive system that, in a smart way, without overspending, identifies those people who are most at risk and finds a way to prioritize prevention for them. This is, of course, the dream for everything we call precision medicine: wearables, biomarkers of every shape and size. But genomics has been consistently the tip of the spear for pursuing this dream. And there's so much going on now that's making this more manifest. There's not only Mendelian single gene diseases that we've been talking about. There's not only polygenic risk stratification, but there's polygenic on top of monogenic, in order to take those people who are carriers of monogenic and be able to prioritize how much they should be worried and how much you should treat them. There's methylation risk profiles that you can add on in real time, along with all of the liquid biopsy technologies. Imagine if you could smartly integrate this, again, focusing on the people who start off at higher risk. So with that, I'm going to wrap up a minute or two early, because I would like to encourage some comments and questions. If they don't circulate mics, I'll just repeat the question. But I would like to remind you that there's opportunity for integration in genomics in your life at every moment, not only when you're born for these inherited conditions, but as you grow up as a child for any kind of issues that are related to milestones. When you become of reproductive age, preconception screening should be top of mind. That is the lowest hanging fruit out there right now. When you move into early middle age, the development of common complex conditions like cancer, diabetes, and so forth. And I would like to encourage you to go to our website, take a look at all of our manuscripts are on our website. Email me with any questions. Follow us on Twitter and Instagram. And feel free to contact us for research opportunities if you're a trainee or know a trainee in this field. Or we have a very quiet service for sort of VIP sequencing that looks at comprehensive sequencing for individuals who are really curious and want a kind of a white glove treatment. Happy to talk to you more about that. So let me stop there and encourage any comments or questions. Thank you. How many of you have had your genome sequenced already? Okay, great. And how many of you with children, without children, or with grown children would, at this moment in time, get your own child sequenced? Wow. Can I bring you to some of the conferences where I'm literally getting shouted down? It's hard to overstate how threatening some of this conversation is to the existing public health system, for very good reasons. It's not because they're Luddites. It's because they live in a world of extraordinarily limited budget, where there is a mission for social justice and universality, where they have been extraordinarily successful but have rarely gotten the credit that they deserve, and where there have been privacy zealots at multiple state levels who've insisted on attacking them and getting courts to destroy millions of invaluable blood spots. So they live in this world where they're super proud of what they do, but they need to keep their head down because whenever anybody hears that the state is holding on to their baby's DNA, it elicits an allergic reaction of enormous proportions. Yes, Ed's going to bring a microphone. She's right there.
So one of the things you said that struck me early on was that we needed to change the narrative. I've been hearing the same thing for years. In the slide you popped up, I believe the thing was insidiously change the narrative. But how would you recommend we do that? I think we've been trying, and do you have any ideas?
Thank you. So I think you heard the question about how to change the narrative. Well, being in academics, I always turn to data, but it turns out data is not enough. We have now, if you take the narrative of catastrophic psychological distress, I feel pretty confident about that one because starting with the REVEAL study 15 years ago, I personally have published probably 7 different data-driven analyses of the lack of distress, and others have as well, in 7 different scenarios. So I think we have to be pretty blunt and say to people when we hear this, no, that's been disproven. Move on. Move on to a new issue. So that's one thing. But the other thing I think is to tell stories that create counter-narratives. When we find people who have had their life saved by early genetic testing and some sort of intervention, even early colonoscopy, we need to get them in front of a camera and have them tell their stories. When we find children, like I have one of the BabySeq children had a pretty severe partial biotinidase deficiency and is now absolutely normal on a simple vitamin dose. They were missed, by the way, by conventional newborn screening. We put those people on videotapes, and I bring them out to conferences like this. And if you come to the conference in Boston in October, I'm going to try to have them on stage telling that story. And so the balance, back when there was not much treatment for genomic diseases, the balance of possible harm in terms of fear, anxiety, insurance discrimination, and so forth was over-indexed on. But now we have medical benefit. We need to not dismiss these, not be cavalier about them. They're all important. Respect them, but more appropriately balance. What's that you say in business? We need to right size the balance of benefits and harms.
Okay, a quick question right here. How much more evidence do you think it'll take to get a U.S. insurer to actually reimburse infant screening sequencing? And then when do you think that'll actually happen?
The question is, when would infant screening be reimbursed through sequencing? Well, I think it depends on the cost. And I think that many others are probably going to go there first. I think that state Medicaid systems might, because they hold on to those patients and it would pay for themselves. Employers might. Consumer-facing opportunities might arise for people. And then I think as these stories accrue, I think my personal opinion is the insurers will be the last. They're very careful about screening tests for good reason. It's very easy to screen for things and then start a cascade of costs from a societal perspective and lose a great deal of money. From a healthcare system perspective, that might be something they're interested in because they could generate downstream tests. I have to stop, but I'll be around for further private discussions, and thank you so much for inviting me.